everyone, welcome back to Instagram Live with Intimate Rose. I'm Dr. Amanda Olson, and today I am joined by Andrea Martin, our menopause specialist extraordinaire. And today our topic is how hormone therapy during perimenopause and menopause affects women with fibroids. So if you have any questions as we go, please don't hesitate to put them in the comments here. And additionally, as we do these series moving forward, each session there will be a special code that you can use to tune in. Our next talk is going to be January 30th, and the topic will be another topic within the menopause space. There's Andrea. Hi. It's clitorises. We have been waiting to see what the brand new backdrop is going to be. I had proposed vulvas, but clitorises, it's even better. Something like, what is it, 70% of women require stimulation to the clitoris to achieve orgasm. Is that right?
On the study, you look at 70 to 80%, and there they are. There was a vulva one I really liked too, but then I was just like, oh, I gotta do it. Clitorises.
I love that so much. It's gorgeous. It's everything I hoped it could be and more.
Me too. Soon I'll add other little trinkets and various weird things that accumulate in this business.
Oh, I cannot wait. So, Andrea, I was just letting people know that moving forward on our fun Andy and Mandy Talk Vaginas Talks, that we are going to be releasing a special 10% discount code that will be useful for a week following our Instagram Live. So people will want to tune in to watch us live and then share the information with their friends, and also they'll be able to use that code. And then for providers that are watching as well, don't forget to give your patients your code, and if you run out of brochures or when you run out of brochures, be sure to email our team at support@intimaterose.com.
Yay, we love a discount. I'm trying to find better lighting for my head. I have to work on this lighting situation.
Look gorgeous as always.
But yay for discounts. They make us excited when we can help our pelvic floors and save money.
That's exactly right. So today our topic is the effects of hormone therapy on women who have fibroids. What's the situation?
What's the deal? It's 411. So I guess first of all, we should define what is a fibroid. So fibroids are super common, benign, meaning they're not dangerous, smooth muscle tumors in the uterus. They will occur in up to 70 to 80% of women by the time they hit age 50. So most of us at some point will be walking around with a fibroid, and you may or may not know it. They're the most common pelvic tumors in reproductive age women. When you look at like ultrasounds, probably like 50% of them end up, noticing a fibroid in there. And then when they looked at hysterectomy specimens, like 80% ended up having fibroids. So super, super common. For most women, they're asymptomatic, meaning they're just hanging out. They're not causing too many problems. But that largely depends on the size of the fibroid, the location of the fibroid. There's different layers in the uterus. So depending on that, if you are symptomatic, symptoms could include like bleeding, pelvic pain or pressure, even urinary symptoms, constipation, if that fibroid is kind of growing and pressing on other areas in your pelvis. So in general, when fibroids are responsive or kind of sensitive to estrogen and progesterone. So for the majority of people, when we go through menopause, they start to shrink because there's nothing really stimulating them anymore. There's nothing that they're going to respond to. Uh-oh. I see an old lady doggy who's starting to bark. Hang on. Sorry. She was sleeping.
I love her so much.
I thought we were in the clear. Okay. She's going to teach us about fibroids. Usually when she's passed out, she's like in another land, but something caught her attention. So back to fibroids.
Clitoris caught her attention.
She was like, what? See, you will never have a fibroid as you don't have a uterus. I don't know if anyone's told you. So again, for most women, go through menopause, they shrink, they're not up to anything. But there is a small subset of women where their fibroids can actually continue to grow. That tends to be more in obese women and women actually that have like much smaller tumors. And we think that's because for obesity, just that fat tissue can produce its own estrogen. So that would stimulate the fibroids. And with those really small tumors, more likely because there's like a higher concentration of progesterone receptors on a small little area. So let's say you have fibroids, you go through menopause, you're having symptoms, or you want to prevent bone loss, and you're like, I want to take hormone therapy. What does this mean for me? So the bottom line, majority of people, no issue. Like fibroids are not a contraindication to hormone therapy. Um, when you look in the Menopause Society, look at their book, they say rarely systemic hormone therapy may cause fibroids to resume growth. So again, this is a very small subset of people, but there have been some studies where there's been like a small increase in size of either pre-existing fibroids that were previously asymptomatic, so not causing an issue, or even formation of new fibroids from like higher doses of progestins in hormone therapy. Again, there's not like a ton of studies that show this, and even in those that did, it didn't reach statistical significance, so not a big deal. The bottom line is, again, most of us when we hit menopause will have fibroids. Um, I've never denied anyone hormone therapy because they have a fibroid. I've never actually had a patient have to stop hormone therapy or even be aware of their fibroids now, because they're on hormone therapy. So it's super, super rare, very, very safe. And also important to remember too, when we give hormone therapy, we're not giving you like premenopausal levels of estrogen and progesterone. We're just giving you a little bit to kind of even things out. So that probably makes the risk even lower of causing fibroids to grow or, to form. So small risk, not really, not really a thing that you see much. So
Very good. And it sounds like it's not getting in the way of their access or appropriateness in and of itself to hormone therapy. And the symptoms that you described sound similar to the differential diagnosis for endometriosis. So that's the changes in bleeding. Do you see heavier bleeding in women with fibroids, or is it bleeding not during regular cycle, or all of the above?
it can be all of the above. Yeah. Just anything that's annoying.
Anything that's annoying and not normal to what they've been accustomed to. And then also the onset of the constipation and the pelvic pain and some of the bloating and whatnot. And it sounds like that's where imaging is really helpful, of getting the ultrasound and finding it. And certainly I've been in observing surgeries during hysterectomy where they've pulled the uterus out and observed those fibroid formations too. And I can appreciate the way that that sits in the pelvic bowl, the compression that it could cause on the bowel,
Uh-huh.
and additionally on the bladder, depending on where it's growing and proliferating, that could also drive bladder symptoms like overactivity, feeling the need to urinate more frequently, sometimes even pain of that pressure
Mm-hmm.
too.
Absolutely. I remember I think it was nurse practitioner school watching a surgery. This poor woman looked like she was 9 months pregnant. Like her fibroids were huge. So she was getting a hysterectomy. And obviously this is not, common. Most people that have fibroids, like I said, don't even know it. But once, especially when it's a more of a size issue, that's when you start to get those symptoms like the constipation, the bladder pressure, that type of stuff, because it's taking up more physical space in your pelvis and taking away space, that other organs should have. Whereas the bleeding tends to be more of the like, where in the uterus is it? Is it closer? Is it disrupting the uterine lining, which then affects the bleeding?
That makes sense.
Mm-hmm.
What else do you like to educate patients in regarding fibroids if you know that they have them on board? So they've had their imaging and it's on board.
So a lot of it again is looking at what the size is, where it's located, what are their symptoms that they're having. Do I think it's even something necessarily related to the fibroid or not? Um, it's so hard in the pelvis, as you know. There's so many things in a very small area and various conditions that can cause the same symptoms. Um, Unless a fibroid is like obviously getting bigger or like, they're having bleeding and it's like, oh, okay, this is, right on the lining of the uterus. I try not to jump to the assumption that the fibroid is the cause, because it becomes very frustrating for people, especially with pelvic pain, pelvic issues, that for a long time go undiagnosed, like they have it and nobody really knows why, and then you get an ultrasound and there's something there, and like people want it to be the answer, which I completely get, but most times it's not the answer, it's not the cause of the thing. So I don't want people to get hyper focused on it, end up getting a procedure that wouldn't actually fix the problem. And sometimes if you end up going to maybe an OBGYN that isn't that experienced in pelvic pain, they're just like, cool, that's the reason, let's go with
Yeah.
that, so that they feel like they can do something about it, but then you end up going down this road, that maybe you may not need. So, I mean, when it comes to fibroids, they can kind of like cut off the blood supply to the fibroid. They can go in and remove the actual fibroid itself. You can take different medications to change bleeding patterns. And then obviously you can just kick your uterus out altogether. Um,
Eviction.
yes. Eviction notice sent. So yeah, that's generally the approach I take to fibroids.
Yeah.
I try not to blame everything on them.
And I love what you said about it would be lovely to see a thing, see a
Mhm.
structure, and want to contribute the driving of pain to that structure and think it's as easy as a surgery. And from a pelvic physical therapy standpoint, that's where we're very interested in the pelvic floor musculature and their movement patterns and their habits, and all of that is a contributor to the pain they're experiencing. So it could be that they are at the same time having fibroids.
Mhm.
As you mentioned, 50% of us in that age group are experiencing those, but the driving of pain could be due to clenching of the pelvic floor muscles, compression on the nerves and vasculature in that very high traffic environment.
Mhm.
Um, and so that's where we manage it using things like the wands to help relieve tension in those structures, and then also teaching them good posture habits and how to properly stoop down to pick up their groceries and all of those good things so that they are addressing the other possible drivers of pain.
Absolutely. I've seen a lot of patients where the focus is all like uterus, cervix, with chronic pain, because that's kind of what they teach in school for what they do when it comes to pain. I always say nobody ever taught anything about a vestibule. Like I think it was like mentioned that the pelvic floor exists, but not like what, how to assess it, all that stuff. So very common for the exam portion of things to just completely miss all that and just let's go to the uterus. So then that's where all the focus goes. But then, I mean, 9 times out of 10, that's not the real issue. Actually driving the pain.
Absolutely. And that's where thorough exam and working together as a team between fantastic women's health nurse practitioners like yourselves and our colleagues in gynecology and urogyne and pelvic health physical therapy and occupational therapy is really important to help that patient really discover the true driver and
Mm-hmm.
get them feeling better.
I love them all. And it is hard when you're the person that has to kind of tell someone, like, I know, like, you want an answer so bad, and you see this on the ultrasound, and nobody's giving you answers, and you're like, I finally found the thing. And then to have me come along and be like, well, it actually might not be.
Yeah.
And it's actually not a quick little fix where we're just going, bloop, pluck it out. It's so frustrating to hear. Um, and can even almost feel like I'm being dismissive to them, which I completely get. But sometimes it takes a little bit for that to settle and be like, okay, let me go down this road now, because these patients have been down so many roads that led to nothing.
I don't see any planet where you are ever dismissive of a patient's symptoms. And I think what the dialogue is that you're not crazy. We do have these findings, but we want to investigate what those other drivers could possibly be. I don't think that's dismissive at all.
That's very nice of you. I know I try not to be, but I could see how, like, even somebody being nice to you and explaining the things, and you're like, no, I found it. This is the thing. We need to go this way. And it's like, no, no, no. This wasn't what I wanted, ma'am.
Change your opinion.
Exactly. Please.
Change your clinical
Yes.
paradigm. That's wonderful. Thank you so much for sharing your expertise on that. Next week, no, January 30th, I do believe I looked at our upcoming topics, and the next topic is endometriosis and hormone therapy and perimenopause and how that can change and what that looks like. So I'm very excited about that. And again, we will have a special code that we'll be releasing during that session. So people will want to tune in live. And in the meanwhile, if they have any questions, they can be sure to put the comments in our comment section on this video once it's posted. DM either you or us here at Intimate Rose, and we will add topics to our series as we go along.
Yes. Tell us what you want to know, and we will research. It's fun because some of this stuff, like, I know it, but I'm like, have I looked up a study in a long time? Like, no. So it forces me to kind of look at the newest data and all this. So I love to know what other people want to know, and then it helps all of our brains.
That's exactly right. And I love how you are always looking at what the most recent literature is. I appreciate that.
A little bit of an egghead. That's why I had to make my research room happier.
It is so beautiful and happy.
Thank you very much.
Well, thank you so much, Andrea. We appreciate you so much. And I look forward to seeing your beautiful face in 2 weeks on January 30th.
As do I. I can't wait. Thank you so much.
Have a good rest of your day.
Bye.
Bye.